Dear friends and colleagues, Assalamu alaikum. Quickly, next 15 minutes, we will revise our basics, the anatomy. And today I will like to talk about anatomy of the aging phase. This is important since we have to select the appropriate remedies for the aged phase. So let's quickly go through the factors that affect the phase and leads to pathological changes or the physiological changes of aging. Our teachers, we always remember them, we are grateful to them and always pray for their highest places in Jannah. We are also grateful to the organizer of this conference for very kind hospitality and excellent scientific session. And there is no conflict of interest in this presentation. Aging is a process of getting older, and it reflects very typically on the face, starting from the epidermis to the deep tissue, pigmented, mottled skin, wrinkled, atrophic face. And some of these changes, not all of these, can be reverted to some extent by these modalities which are available. We can treat the surface with resurfacing techniques, the tonicity of muscles can be relaxed, and we can reposition the drooping superficial fat, only the superficial fat, not the muscles, and we can refill the atrophic deep fat pads. But let's go to the basics. The classical layer structure of the skin, of the face. This is very important, since we target specific area where the changes which occur with the advancing years, starting from superficial, it's the skin, then the subcutaneous, then is the smash, starting from platysma to the muscles of facial expression, then to the frontalis, and deep to that, deep fat pads and the periosteum. These layers, they are attached to each other by the fibrous bands like this one, and we call them retinoculum. And these retaining ligaments, they keep these layers of the face together, but at the same time allow certain degree of movements on each other. The retaining ligaments, classically, they resemble the branching tree. On the deeper side, they have thick fibrous band, but as they approach to the dermis, they become thin and thin, and then they intermingle with the reticular dermis. And these fibrous band, they are keeping these 5 layers attached to either, but at the same time, they allow some movements. Again, repetition, the superficial fat, the muscles, and some area, it's a fibrous tissue. Then we have the deep fat pads, and then the periosteum. These are the 5 layers, and they are affected to various extent with the aging process. And the changes that occur during aging is important in order to select the appropriate remedy. Again, the cadaver dissection showing the layer structure of the face, the skin, along with the subcutaneous tissue, and this is the smash with the overlying superficial fat, and deep to that is the deep fat. These are the compartments of these deep fat. Deep fat is compartmentized because of fibrous band that are keeping these deep fat separated from each other, and that's why when you inject specifically to each of the compartment, the injected material remains localized to that particular area. And this is the, sure, why not? And this is the main framework over which all layers of the face, they are lying, and the most important changes with aging occur in this skull. And these are the changes which occur in the skull. The skull itself becomes atrophic, it shrinks, and there is especially retusion in the maxillary area and the mandible, and these resorption of the bone that gives the impression onto the surface of skin as the cadaveric look. The orifices, the orbital opening that also enlarges, especially supromedial and infralaterally, and that's why you have to compensate these atrophic changes by injecting onto the periosteum. We cannot do with the skull itself, but you can compensate to some extent the changes of this atrophy on the skull with injecting onto the supraperiosteal area. These are the main areas which are absorbed during aging, especially the maxilla that retrudes, and that's why we inject in the deep medial cheek compartment. And the scientific study has shown that the height of midface decreases to about 10% in males and about 6.7% in females by the age of 70 with advancing years. Since the skull, the height of skull itself decreases, the overlying envelopes, they sag down and they drop, and that's why we get this jowling on the mandible. The volume of skull itself also decreases. See, there is about 70 milliliter, meaning thereby 70 syringes of hyaluronic acid are needed to compensate this decrease in the volume of the skull, and this is seen by the age of 70. And especially the changes are prominent in the maxilla, and as I said earlier, that's why we inject the deep medial cheek compartment. Showing the ligamentous attachment, and these ligaments, by way of their attachment to the bony surface, give rise to certain compartments, and that's why when we inject in these compartments, the injected material remains localized into that particular area. And the knowledge of these is helpful when you are planning to inject deep onto the periosteum. This is the strongest mandibular ligament, the zygomatic ligament, and lateral-temporal adhesion. These are the true retaining ligaments of the face. True in the sense they arise from the periosteum, and then they go all the way to the reticular dermis. The false ligaments, they do not arise from the periosteum, rather they originate from the muscles envelop, and that's why they are not very strong one. Again, the deep fat pads, and an important one, the medial suve, lateral suve, and especially important one is the deep medial cheek fat pad, since we inject this area and we can compensate, since the maximum retrusion is seen in the maxillary area, and this fat pad also lies over this area. So if you inject this area, you can compensate to certain degree the changes which are seen with the advancing years. This is a resemblance in the young age. The deep fat pads, they are just like grapes, but with the advancing years, the majority of fat get absorbed, and that's why you volumize these fat pads. And this is the surface presentation because of the absorption of bone, because the overlying fat atrophy, you get the changes on the skin, and if you want to revert these, you have to inject onto the periosteum, not into the superficial fat. The commonly used hyaluronic acid not only acts as a filling agent, it has got other properties. The lower molecular weight hyaluronic acid is inflammatory, but the higher molecular weight is anti-inflammatory. So when you appropriately select the quantity and the quality of hyaluronic acid, that is also reflected on your results. Nowadays, HA fillers, they are incorporated with many of the other chemicals like vitamins, and especially important is the PCL fillers, but these PCL fillers often give rise to inflammatory response, and they cannot be resolved with the hyaluronidase. So be conscious when you are using mixture of HA filler with some of the components. The vasculature, you have to be careful, and the certain anatomical area where there is submersion of neovascular structure, you have to be conscious when you are injecting onto the periosteum. The third layer, it's the SMAS, the superficial musculoepineuritic system, and these are the muscles of facial expression. The muscles themselves, they atrophy, but their tonicity increases. And the main reason, again, being is that the skull itself shrinks, and that's why the muscle become hypertonic to keep the opening of orbit and orifices patent. So the muscle tonicity is increased with the advancing years, although the mass of muscle is decreased. You are familiar with their actions, and the appropriate selection of the points is helpful to decrease the unwanted wrinkles on the face, and these reside in the third layer. Now we come to the superficial fat. Superficial fat is the second layer. It doesn't change with the age. It only changes with the body weight. But the deep fat, that atrophies. And there is loss of 1 to 2% starting from 40 years. And by the age of 50 years, more than 40 to 50% and about 70% of the fat is lost when you are more than 70 years.
नहीं सर, आजकल तो ज़्यादा जल्दी लूज हो जाते हैं सर। आजकल वो because of massive weight loss, और वो जो अल्लाह के फजल से ओज़म्पिक आया है, और उसे तो मेरे ख्याल साल के अंदर ही जितना आपने ये बताया 70%, आजकल ज़्यादा तो 70% विद इन ए ईयर हो जाते हैं। लेकिन उसका ये फ़ायदा भी है कि वो पेशेंट्स आपके पास आएंगे ट्रीटमेंट के लिए, मैसिव वेट लॉस के लिए।
Even 70% weight loss by the age of 70 is a very big one, and that's why we mainly inject in the deep tissue instead of injecting the superficial one. The superficial fat, which is the second layer of the skin, doesn't change with the age. It only drops down, and the reason being there is a shrinkage of the skull, the whole volume of skull shrinks, the deep fat pads, they atrophy, and that's why it drops down. And to revert these changes, then we go to these so-called lifting threads. In fact, they are not lifting threads, they are repositioning threads. They are simply helpful in repositioning the superficial fat. They cannot lift the muscles, and they cannot compensate for deep atrophic fats. And the other way of compensating these fat pad is to inject to the filler. This is a very fascinating video. I have seen it about 7 years back, and it displays that you can lift the jawline with these lifting or so-called repositioning thread. But this actually is not defect. It's more of a fiction. You cannot lift this jawline, which is because of loss of mandible, and this is because the muscles fibers, they are pulled down by the platysma bands. You can only lift with these repositioning thread, the dropping superficial fat. So be cautious and be aware of this type of misleading advertisement or video. This was in fact from a medical website. Again, if you look to the aging changes, the aging is because the mandible regresses, there is loss of deep fat pad, the platysma bands, they become hypertonic, and that leads to jawline. So you cannot lift this whole jawline with these lifting or repositioning threads. The best way is to relax these fibers, these muscular band of platysma, to fill this deep atrophic fats and to compensate this regression in the mandible by injecting either onto the periosteum or in the subcutaneous area. In fact, although you may get immediate improvement, but because of strong movements of the muscle, this improvement cannot be maintained unless you go to the additional injection of toxin to that area. This is again representation what happens with the advancing year, the deep fat atrophy, and the other way of repositioning these dropping superficial fat is you inject in the armpit, and that's why this concept of the 5 points of filler injection that you inject in the armpit of ligaments, and when you inject in the armpit of these true osseous ligaments, then you can live to this some extent. The other very popular method where we insert multiple PDO threads in the superficial fat in order to claim lifting is not possible. There is some new collagen formation, but that is mainly because of injury. This was a thigh. Only 30 seconds. This was an experiment done by Thai surgeon. He inserted a needle on one side and needle and thread on the other side, and after 6 months, the improvement was same on the both sides, meaning thereby the new collagen formation that probably resulted only because of injury of needle. And the thread, the contribution of thread was minimum. And a French plastic surgeon did histopathology, and he claims there is no new collagen formation with PDO threads, only type 3 collagen formation, which is collagen seen in the scar tissue and not very good one as compared to type 1. Polylactic acid is a good option. We are going to have one presentation later probably in the evening or afternoon on polylactic acid, and that does give new collagen formation, but again for limited extent. And the last one, the skin. As a dermatologist, we are familiar the changes which are seen on the young skin and the aged skin, and the changes, they are more marked on the skin which is exposed to sunlight, and the atrophy of skin is exaggerated by the environmental factor, although the genes do play important part, but the environmental factor are important, and especially one is the skin. This is the patient. She was in habit of using this sort of veil, and if you compare the skin of the area which was habitually covered with veil and the area which was exposed, you can see the age of this skin, and this is the same one, but this was protected from the damaging effect of sunlight, and that's why the changes are minimum. The best way is probably this one, but may not be acceptable to our but probably it's not acceptable in our modern society, but we can go for this one also. Probably this is acceptable one. And then are the resurfacing. There are many options available, starting from daily bedtime use of retinoids to the hydroxy acid. There is no very hype of retinoic acid, but adapalene, which is economical one and more safe, is more effective as compared to retinol. And the fractional concept of fractional resurfacing has changed the whole era of skin resurfacing, especially in our pigmented skin, which the whole of column of epidermis and dermis, they are removed, and the downtime is minimum. And if you closely look on this actual video, apart from the ablation, there is shrinkage of collagen on the surrounding skin which is not treated. So that has got dual effect. Not only ablates the column of skin around 10 to 15%, but the surrounding skin also shrinks and you get tightness. And again, to summarize, the changes which are seen with the aging, or the anatomical changes which occur on the face with aging, especially important is the bone, resorption of bone. More than 10 to 30% of the skull is absorbed, and there is a preferential absorption on these certain areas. Then the ligaments, it was thought that ligaments become lax, but in fact they remain tense. Instead, there is absorption of fat and the bone, and that's why you get some creases where the ligaments are present. The deep fat pads, that atrophy, there is a minimum effect on the superficial fat. Its thickness remains the same. Instead, it only drops down, so it's logical not to inject in the superficial fat, go to the deep fat, and the muscles increase their rigidity and skin becomes lax, and these are the some of the changes. Thank you for listening.